fact that cardiovascular diseases are extremely common in people who succumb to this virus, and as well as people with the cardiovascular diseases predispose patients to develop this virus in this severe form. So, whereas the disease has spread all over the world with variable frequency and mortality in various places, in Pakistan, we still have a lot of cardiovascular diseases coming to the hospitals who are either corona negative or corona positive. And it's very important to know how best to manage them, because there are a lot of questions about the various pharmacological agents. There's a lot of discussion going on various subjects. But before we invite our speakers, I would like to introduce them. Our first speaker is Professor Sohail Khan, senior interventional cardiologist from prestigious Queen Elizabeth Hospital, Birmingham. He's also a senior clinical lecturer at the University of Birmingham Medical School, a very frequent visitor to Pakistan in our Pakistan Live. Thank you very much, Dr. Sohail, for accepting our invitation and being with us this afternoon. Our next speaker is Professor John Townend, again from Queen Elizabeth Hospital, a very senior cardiologist and academician, who's going to talk about his experience, how they are managing the cardiovascular patients with COVID positive cases. We also have two very distinguished panelists, one from Philippines, Professor Sinthia de Laura, member of the Philippine Heart Association, chair of CPR and various other committees. Then we have Professor Saulat Siddique, current president of Pakistan Hypertension League and a professor of cardiology at Lahore, a very senior list, and the speakers to be with us. And of course, we have got a great number of participants who are registered with us for this afternoon, and we'll have a question and answer session after the talks. We have a number of queries that I think will unfold during the discussion. So without much delay, I would like to invite our first speaker, Dr. Sohail Khan from Queen Elizabeth Hospital, Birmingham, to kindly give his talk on the heart disease management in COVID-19 era. Dr. Sohail Khan.
Right. So, it's a pleasure to take part in this webinar. So it's great, linking Europe with South Asia and also Southeast Asia. And I'm very grateful to GETS Pharma for putting this together at such short notice. Professor Ishaq, Professor Siddique, it's great that the Pakistan Hypertension League has been able to support this, and also my colleague, Professor Townend, and Dr. Delara, who's joining us from the Philippines. So I'm going to just share my screen with you, and hopefully you'll be able to see that very shortly. There we are. Okay, so what I'm going to talk to you about today is ischemic heart disease and its management in the COVID-19 era. What we know is that, unfortunately, Birmingham has become an epicenter for the COVID-19 virus within Europe. So Birmingham, for those of you who don't know, is the second biggest city in the United Kingdom. We're about 100 miles northwest of London. We have a population of 1.5 million. And if you look at the bigger conurbation area, we have a population of around 5 million. Now, what will become important later is that we're an industrial city, but also a city with a large Black and Asian minority ethnic population. Now, just to the south of the city, what you've got is the biggest hospital in Birmingham, which is the Queen Elizabeth Hospital. This is the largest hospital and part of the University Hospitals Birmingham NHS Trust. We have 1,200 beds. And what are we known for? Well, we're known for the largest intensive care unit in Europe. We have over 100 ITU beds available at our institution. We're also the largest solid organ transplant center in Europe. So if you include hearts, livers, kidneys, we do more of these than any other center in Europe. And of course, we're known for our cardiology. So we have a number of consultants, over 25 consultants. We perform complex PCI, rotablation, laser atherectomy. We use a lot of intracoronary imaging. We're also one of the 3 centers in the UK which provide a robust impeller service. And we have a good structural program as well, including TAVI and adult congenital heart disease and EP. So essentially, we're providing all the main services to our population within the city. And as Professor Ishaq mentioned, we've got some fantastic links internationally. So we've had a history of training international fellows. You can see some of our fellows on these pictures here. We've had trainees from Italy, from Milan. We've had trainees from India and of course from Pakistan as well. And as Professor Ishaq mentioned, I've personally partnered with the Pakistan Society of Cardiology, Interventional Cardiology, and most recently Cardiacon. And I'm sure some of you will recognize some of the faces of individuals on these slides. And I've been honored to be a guest operator at many of the major heart centers within the cities of Karachi, Islamabad, and Lahore as well. So where does this story start? Well, actually, it starts back in December 2019, and it seems like a terribly long time ago, but it was only 6 months ago. And what happened was that within the city of Wuhan, in the Hubei province of China, there were a cluster of cases that were reported subsequently in the Lancet paper, 41 patients who had presented with severe bilateral pneumonia. And this was subsequently diagnosed and classified as a novel coronavirus. What's interesting is that there's a big meeting that takes place in China, the Chinese Bifurcation Summit. And actually, I was there just about 200 miles away east of Wuhan when all of this was happening. You can see I'm doing a live case at the meeting there. Of course, we didn't know anything about this until I'd returned. Now, the constitutional symptoms that occur with this are fairly typical. Patients usually present with cough, shortness of breath, with fever. Most recently, we've realized that there are other symptoms as well. Diarrhea can occur. Some patients lose their sense of smell. The patients usually have elevated inflammatory markers, so high CRP, elevated liver enzymes, particularly the ALT, ferritin D dimers. And in this case series that was reported in the Lancet in January, 5 out of the 41 patients also had elevation in their troponin as well. And you can see this sort of typical appearances of a chest X-ray. This is one that I picked up from our emergency room department. Bilateral pneumonia affecting predominantly the mid and lower zones. And it's a pretty nasty looking pneumonia, multilobular, affecting subsegmental areas. So the world, I have to say, was a little bit slow in terms of picking up the fact, even though these cases were reported in the journals in January. We didn't have our first case in the United Kingdom until the 31st of January, but I suspect we probably had it earlier than that. If you look at our numbers, we were essentially 2 weeks behind Italy, and our fellow who we'd sent back to Milan was warning us that there was this tsunami on the way, but actually our government wasn't really listening to any of this. The coronavirus action plan didn't come into being until the 3rd of March. And remember, it was the 11th of March that WHO called this a pandemic. And it was only then that our government sort of kicked into action. And on the 12th of March, they raised the risk level to the highest risk level. And at that stage, what was decided within the country was that the National Health Service had to postpone all non-urgent operations with a plan to free up 30,000 beds. Now, the NHS usually has around 100,000 beds, so this was a third of the capacity that they wanted to free up in a very, very short space of time. Unfortunately, you can see these are figures from only yesterday. We've unfortunately reached this milestone of 40,000 deaths within the United Kingdom. Although I'm pleased to say now we are seeing a decline in the number of cases, certainly new cases that are being diagnosed within the UK. So we didn't go into lockdown until the 23rd of March. And essentially, we are in sort of a lockdown even now that we've entered June, although some of it is easing a little bit. Now, what was happening in our hospital? Well, our hospital became an epicenter of the virus, essentially. And you can see here, within April, that was where the virus peaked within the United Kingdom. And that we had at one stage over 700 patients in our 1,200 hospital beds who had been diagnosed as corona or COVID-19 positive. We had, and we were the busiest intensive care unit as well in Europe. We had at one stage over 170 ventilated patients. And if you speak to our hospital staff, they said that we had capacity probably for 3 times that number of patients, and certainly ventilators that were being rapidly made around the world so that patients could be dealt with adequately. Now, although COVID-19 affects the respiratory tract, what's becoming clearer is that actually there are a number of patients who are presenting with myocardial injury, particularly in terms of raised troponin levels. So these are some of the putative mechanisms of how and why myocardial injury might be present in patients who have COVID-19. What's becoming clearer is that this virus seems to be targeting individuals who have underlying diabetes, underlying hypertension. So it might be that it's unmasking underlying cardiovascular disease. We know that it may be acting in terms of causing plaque instability, type 1 myocardial infarctions, but probably more likely it's the oxygen supply demand mismatch that occurs, and type 2 myocardial infarctions that we are predominantly seeing. So, we know that patients will present with increased episodes of hypotension, increasing metabolic demands, and even the drive of the severe hypoxia will end up leading to a release in the troponin. Recently, of course, we've seen evidence of increasing microvascular injury in these patients, and there's focus now on disseminated intravascular coagulation. And what's becoming evident is that actually the virus seems to be affecting more so the right rather than the left ventricle. There's some data which is coming out suggesting that it's causing RV dilatation, particularly in ventilated patients on intensive care units. There is some evidence of in the literature at the moment of myocarditis, the virus causing a myocarditic type picture. Most of this is actually circumstantial. So the case reports that have appeared in the literature have predominantly done cardiac MRI scanning. As far as I'm aware, there's only one case report in the literature where they've performed endomyocardial biopsy. And in that particular case report, they didn't actually find any virus within the cardiac myocytes, but what they did find was presence of T lymphocytes. We know that actually the virus enters the cells via the ACE2 receptor. Now, most of these receptors are based on the type 2 pneumocytes within the alveoli, but there are also some receptors on the cardiac myocytes, and this may be a putative mechanism of entry of the virus into the myocytes. Stress cardiomyopathy is also a possibility. So there's cases that have appeared in the literature telling us about Takotsubo's occurring, and also, in fact, reverse Takotsubo. And then, of course, late on in the disease process, and this is probably one of the most feared complications, is this risk of cytokine release and sort of a systemic inflammatory response syndrome, probably mediated by interleukin 1, interleukin 6. Now, of course, just because the virus has gone and caused a pandemic around the world, cardiovascular disease doesn't stop. Cardiovascular disease still is occurring, and we know that cardiovascular disease, unstable coronary syndromes, ST elevation, non-ST elevation MIs will still be taking place. What has happened, and I'll show you some of these slides going forward, is that some of these numbers of cases certainly appear to have dropped. Now, of course, what we know is that this is a life-threatening condition, so patients who present to hospital with myocardial infarction are at risk. This is an easily treatable condition, and of course, it's time critical as well. So, we all have pathways that are in place in terms of treating patients with ST and non-ST elevation MI. And what we need to do is not affect those pathways too broadly. We need to think about the effect, of course, of the virus on rotors. And what we've seen in our institution is that there has been some redeployment of staff to intensive care units. We've seen redeployment of consultant staff also to the front line as well, including myself for a short period of time, managing COVID at the front door. And we mustn't forget that actually at any given time, a proportion of your staff may well be off sick or ill with the virus, either in themselves or having to self-isolate because of illness at home. One of the things that shouldn't be underestimated is the psychological effect that the virus has on the teams. And of course, the institutions that we work in are important, and one of their roles is to protect their workforce. Now, our trust took a very early stance in this and decided that actually personal protective equipment was going to be something that they were going to concentrate on during this. And all of us who were working frontline were fitted with these FFP filtering face piece masks. This is an FFP3 that you can see me wearing. The actual FFP3, it's not just a case of just putting the mask on it. You actually have to go through a number of tests. You can see there's a tube attached to this FFP3 mask, and you have to undergo tests to ensure that the FFP actually is suitable for your face. There are a number of these that are available. You have to go through breathing exercises, normal breathing, deep breathing, breathing with in different positions as well to make sure that the mask is actually fitting you. The other important thing is, of course, appropriately donning, which is putting on the personal protective equipment, but also doffing as well. Doffing is, of course, a higher risk procedure because doffing involves you removing the equipment when you're potentially contaminated. So you have to be able to practice that several times before you go live in your cath labs so that you're very familiar with what needs to be done. Now, this is some data which I think is important to share. This is from the Open Safely Collaborative. The virus, although everybody is at risk of the virus, there are certain groups of individuals who seem to be at higher risk, particularly elderly. So the older you are, the higher your hazards ratio of dying. This is over 5,000 deaths that were looked at in this particular case series. It seems to affect males, I'm afraid, patients who are obese. This is interesting. It tends to affect patients who are Black, Asian, and ethnic minorities. So we've seen an increase death rate, particularly within healthcare workers, and unfortunately, over 100 of healthcare workers have passed away in the United Kingdom and a big proportion of those are unfortunately patients, colleagues from Philippines, from India, from Pakistan, from North Africa as well. And deprivation is also a big risk factor as well. So the virus seems to be targeting individuals who are poor. Now, of course, these are not mutually exclusive. What we're seeing is probably individuals who fit into several of these categories. Now, our centre in the UK, we've been up and running with primary PCI for a number of years, certainly before I started there as a consultant. Now, one of the things that we had discussions about at the early stage was, should we go back to fibrinolysis for patients who are presenting with an ST elevation MI because of the operational challenges that we might have in trying to get these patients to our cath labs. Now, we decided as a group that actually this was probably not going to be advantageous for the patient. We know that primary PCI is far superior at reducing risk of death, myocardial infarction, also bleeding in patients as compared to thrombolysis. And we also know that there are a proportion of patients who will undergo thrombolysis who will not reperfuse. So they will end up requiring cath lab services further down the line for rescue angioplasty. That can be up to a third of patients. So we took an early decision that we will continue our program of primary PCI and also work for patients with STEMIs as well. The other concern, of course, and this is becoming more evident as the literature on COVID is growing, is that there are a proportion of patients who are presenting with ST elevation MI, maybe a third of them, who maybe don't have occluded vessels, are maybe presenting with a myocarditic type picture. And of course, we know that if you thrombolyze these patients, there is a substantial increased risk of bleeding. So what was seen around the world? The data here on the left is from Iran, one of the first countries which was heavily hit with the virus. And you can see there around Tehran, there was a big drop-off in numbers of patients presenting to the hospitals with ST elevation myocardial infarction. So in February and March, there was a 40 to 50% drop-off in these 4 hospitals that were treating patients with ST elevation MI. That phenomenon was also seen in other parts of the world. So in California, this is Oakland in California, North California. There was when they compared their figures in March and April to the same period in the previous year, they saw a significant drop-off in numbers, and that seemed to correlate with increasing levels of COVID-19. This, however, wasn't the case throughout the world. So here the experience from Milan, where they have a hub and a spoke model for managing patients with acute coronary syndromes, they actually saw a 2.5-fold increase in their number of cases. But what was evident was that actually patients were presenting significantly later than they would have done otherwise. So their normal presentation for ST elevation MI was 6 hours, but in this COVID era where they measured things, their patients were presenting at 24 hours. And this subsequently meant a higher risk of mortality in that group of patients. So their in-hospital mortality was 4 times higher because of that and the complications related to patients presenting later. When they asked the patients, and all the patients were questioned about this, the biggest thing that the patients were concerned about was the fear of admission to a potentially infected environment. So one of the things that we have to get out in terms of messages is that actually hospitals are safe. We are still treating patients with coronary disease, and patients should still present if they have emergency conditions such as infarcts, strokes, etc. So what have we been doing in our institution? Well, we've been following this sort of published algorithm. This was published by Sky and ACC, ST elevation on the ECG, all patients essentially will go to the cath lab for primary PCI. Positive and probable patients, we will think about doing point of care ultrasound scans. We will think about doing chest x-rays and even CT scans if we're not entirely sure about whether the patient is positive or not. We've just had made available to us ultra rapid testing at our institution, but even ultra rapid testing is it's meant to take 15 minutes, but in reality it takes 45 minutes. So we will prepare all patients with full PPE in our cardiac cath labs. So what has happened in our cardiac cath lab? Well, we've had to change the way that we've configured our labs. And this is primarily to reassure patients, but also to protect our staff as well. And you can see when patients appear who we assume are COVID positive, who require emergency procedures in the cath lab, we will shield off, we have 4 labs in total, we will shield off our 2 cath labs, which are dedicated COVID labs, so that the patients can undergo the procedure quite safely. The patient will be held in the ambulance until all of the staff members have arrived and are appropriately protected with full PPE, and that includes FFP3 masks for all individuals, radiographers, cardiac technicians, and also the cath lab staff, and the patient will wear a mask. Other things that we've had to do during this time, of course, ITU hasn't been available to us because so we've had to sort of change the sorts of patients that we're treating within the lab. So as a result, we were always a radial hospital, but we have increased our radial procedures even further. We've gone from 85 to 95%. And we've also, believe it or not, started sending some patients who are low risk on the Saulat score home within 24 hours after having an ST elevation MI. Of course, we're doing a lot more day case PCI as we're dialing down our acute work and going back to elective work. We know that a proportion of patients who present will require further follow-on revascularization as well. So we're tending to do that at the same time for patients. And all these patients are being isolated until we have a result back. And that is really just to allow that information to filter through to the population that we are treating these patients separately. Now, the thing is that the virus is here to stay. So this is not a sprint. This is more of a marathon. So we're in for a long run here. And screening is going to be very important going forward. So our trust is screening all patients now coming through the front door, but screening is also available for staff. And as of last week, antibody testing has been made available for staff as well. As we're transitioning to elective work now, what we're doing is where we have availability of ITU, our cardiac surgeons now have also started to operate once again. And what we're doing is separating our acute cases from our elective cases and screening patients at the front door prior to their admission. So we have a self-screening, self-isolation policy for patients. So they have been told to self-isolate for a week before they present. They're having temperature checks prior to having their procedure done. Outpatients have been affected in a big way. So we've transitioned now to telephone phone call follow-ups and also video consultations. And now CT wasn't available to us during the month of April, but we're beginning to see non-invasive testing coming back online. And one of the things we mustn't forget is, of course, if you're a big teaching hospital like we are, we have medical students, we have fellows coming through our departments from around the world. We've gone back now to training these individuals. The medical student teaching now is being done remotely through lecture series rather than face-to-face and clinic work. So this is my final slide. The question is this our new normal now? Empty shopping centres, face masks when we go out. We heard only yesterday from WHO that they are now advising face masks for all people when they go out. Our government have said that people wanting to go on public transport will be mandated to wear face masks. What some of the positives that have come out of this? Well, I think we're working better as teams. So what we found is that we're more supportive of each other. We're more caring towards each other, and that can only be a good thing. I have put together with the Royal College of Physicians a doctor's diary, sort of a day in the life of what my role has entailed during the COVID crisis. And there's another webinar that I took part in, which tells you a little bit about the changes that we experience in our rotas. This was put together with colleagues from London and also Manchester. So I'm happy to share these slides with you. And I'm going to leave you with this quote from Margaret Mitchell from Gone with the Wind. We always ask, why has this happened? Well, I'm afraid life is under no obligation to give us what we want. Thank you very much.
Hello.
Hi.
Thank you, Dr. Sohail, for an excellent talk. I think we have a couple of questions, but I think we'll keep it to the end. It's now my pleasure to invite the next speaker, Professor John Townend, again from Queen Elizabeth Hospital. I think John is going to present a case and then tell us how he's been managing these patients in real life in the hospital, the experience at Birmingham, and then we may have somebody from Pakistan to share the experience we have at the National Institute of Cardiovascular Diseases. So, John, it's yours now.
Thank you very much. I hope that everybody can hear me. I'm really delighted to be able to take part in this excellent webinar. I'm just going to start off with a few thoughts, just leading off from what Sohail was talking about. It's been one of the nice things about the whole thing actually has been that we have come together as a group, and working with some great colleagues has been actually a very positive experience from the whole thing. I'm going to start sharing my screen now. I hope with some slides. Okay, can people see those slides? I hope. So the title of my talk is Last Thursday Morning, because this is the last patient I treated by PCR, which is just about a week ago, who had some interesting aspects of the COVID problems. So, I mean, just a couple of minutes of leading on from Sohail. I mean, the whole thing caught me slightly by surprise. It came much more quickly and suddenly and got much worse than I thought it would. But actually, it went very quickly too, and we're not seeing very much at all anymore. The whole thing was probably over in roughly 6 weeks, although there's still a trickle of these patients coming in. But the COVID positive patients are not affecting us so much anymore. But the effect of the COVID patients has had a dramatic effect on our working life. We're still doing very little elective work, and we still have a dramatic reduction in the number of acute coronary syndrome patients, both ST elevation, myocardial infarction, and the end stems. I think our work went down by, I don't know what Sohail would think, but probably more than half, and it probably isn't back to any more than half at the moment. It's very quiet. And these patients, I think, are sitting at home with their chest pain, not presenting, and that's very sad. The PPE has been a big thing. Donning it, wearing it for long periods of time and doffing it is uncomfortable. It introduces delay, and that needs to be thought about when you're setting up your systems. And it's a real nuisance. It takes away that face-to-face ability to talk to patients and to try and reassure them. They're all of a sudden they're staring at somebody behind a mask, and that's uncomfortable for both the doctor and the patient. I suppose one of the positives is that we saw several thousand patients with COVID-19 disease, and all of us have had direct contact with patients with florid disease, and actually, thank goodness, very, very few of our staff have become infected. Nationally, I think we've had 100 sad deaths, but when you think of the tens of thousands of people that have been involved, the PPE must be remarkably effective. or this virus is not quite as infective as we think it is for a predominantly healthy healthcare population. And then the other thing I was expecting is that we'd be asked a lot to see COVID-19 patients with troponin rises, with funny ECGs, funny echoes. But actually, most of the patients I saw, the diagnostic difficulties were not great, because most of the patients that I saw with bad cardiovascular COVID problems also had bad COVID respiratory disease. So it wasn't a diagnostic difficulty. It was relatively straightforward to think, well, this is a COVID-related problem. Anyway, onto the case. So this is last Thursday in our cardiac cath lab. I'd done the first case, an acute coronary syndrome patient who didn't have much in the way of coronary disease, and I was wondering what I was going to do for the rest of the day because we didn't have any more patients at that stage. And then we got a call from our emergency department. A gentleman, 69 years of age, with no known past medical history at that stage. In fact, at that point, we didn't even know his name. Had been picked up by the ambulance after collapsing at home. And I'll give you a little bit of history that sort of became evident later. Later, we found that he was known to be in atrial fibrillation and was on apixaban as an anticoagulant. As far as we can tell, he's still, apart from that, he has no major risk factors. He was not diabetic, not hypertensive, and his cholesterol was thought to be normal, and he'd never smoked. Now, this is important and is one of the big lessons. He had 2 continuous days of intermittent chest pain, and he had failed to present to any doctor. So, this I think illustrates how problematic the whole thing is. Patients are sitting at home with their symptoms and not seeking medical attention for worrying symptoms. And I think normally he probably would have come up to hospital or presented to his general practitioner. And again, importantly, he had no history of fever or cough or anything else to suggest viral or COVID infection. And what happened after his 2 days of chest pain, his wife had gone downstairs to make his breakfast. She heard a bang on the floor. She obviously got worried and went upstairs and found him collapsed, unconscious. Now, she's not medically trained and she didn't take his pulse, but I suspect at this stage that he probably had no pulse and he probably was not breathing. And she did the only thing that she knew to do, which was to ring 999, which is our ambulance service, and ask for an emergency ambulance call. She did not perform any CPR, so this poor chap was left lying on the floor, unconscious, with nothing being done to him. And our excellent ambulance service, and they are highly efficient, I must say, around us, arrived in 6 minutes. So it's from the time of her call, they were at that house in 6 minutes. So that was a pretty rapid arrival. Then another thing that's important for the COVID issues is that they then had to treat this patient as if he might have COVID infection, so they had to don their protective equipment, and that probably took another 5 minutes. They then got to the patient, put on their ECG leads, and found him to be in ventricular fibrillation. They performed CPR, and after several minutes of CPR and 3 DC shocks, they eventually got him back with a return of spontaneous circulation. Looks like it's probably an atrial fibrillation at the ECG, and left the scene 60 minutes later to bring him into the hospital. They put down a laryngeal mask, and on arrival in our hospital, he was intubated and ventilated. And actually, hemodynamically, he was in remarkably good shape. His blood pressure was over 100, and he wasn't particularly acidotic. So maybe he wasn't out for quite as long as we thought he was, or maybe their CPR was highly effective. This was his ECG, and you can clearly see it's abnormal. It's a slightly unusual infarct pattern, but I think I hope I can persuade you that he's got significant ST elevation in those high lateral leads, 1 and AVL, and some abnormalities in the inferior leads that were consistent with sort of reciprocal change. So we thought this was probably a case of STEMI. So we set up our cath lab. We all had to don our full personal protective equipment. The patient at this stage did not have an NG tube, so we had to get some aspirin into him somehow. So we gave him rectal aspirin. And then we performed a coronary angiogram from the right radial artery. And this was his right coronary, which you can see is a little bit atheromatous, but has TIMI3 flow down it and probably no high-grade lesions. This is the left coronary artery, and you can see immediately my eye was caught by that severe circumflex disease and that rather tortuous-looking circumflex. And then we went to a cranial view, and there's his LAD, and that looks pretty pretty good. What you can see, however, is that there appears to be a very small stump of a diagonal, and I wasn't sure at this stage whether his ECG changes were related to that diagonal, which would fit with a lateral infarct, or whether we should concentrate on the circumflex. So I'll be interested to hear what other people think later, perhaps. For what it's worth, I thought it might be the diagonal, so we wired it. Of course, you never really know what you're going to get, but the wire went a good distance and we ballooned it and found a lesion and then put in a small stent. And there we go, quite a big diagonal turns up. Now at this stage, I thought we'd done quite good things to that diagonal, but you can see that that we did have, show that again, a residual osteal stenosis. Now, since we had TIMI3 flow, and I thought that treating that osteal stenosis would be likely to result in some quite complicated bifurcation work around this LAD diagonal, I thought probably that would be better left at this stage. So I opted to move on to the circumflex, and you can see even after wiring that circumflex, it's a very tortuous vessel and it hasn't straightened out with the wire. This is a nasty, rigid vessel. We did manage to get balloons round pretty easily, but then it proved very difficult to get a stent round. So we had to use a Guidezilla device, which we had to entrain down the circumflex with the use of an inflated balloon to get the Guidezilla right around the corner and then deliver the stent, which we were able to do. And of course, we had to inflate that balloon just to sort of push the whole thing down. So there's our stent being positioned. And then we had to put in another stent because, of course, pushing that thing down had messed up the proximal circumflex. So there's 2 stents in the circumflex, which looks pretty respectable now. We covered the procedure with double bolus eptifibatide in the cath lab because we've been unable to give him any ticagrelor at this stage. He was hemodynamically stable right the way through the procedure, just needed a couple of doses of phenylephrine just to keep his blood pressure good. He then went back to the intensive care unit in good hemodynamic shape. They put an NG tube down, they loaded him with ticagrelor. His initial COVID swab, the fast swab, which comes back in a couple of hours, was negative. But slightly to my surprise, his second swab at 24 hours was positive. And you could speculate that perhaps this is a case of viral infection causing, as Sohail was saying, causing inflammation and instability in that atheromatous plaque in his side, and perhaps that's why he had an S-elevation myocardial infarction, because he had an asymptomatic, or otherwise asymptomatic, COVID infection. There were only minor chest X-ray abnormalities. There was no problem oxygenating him, so if he did have COVID pneumonia, it was pretty minimal. He required minimal pressor support in the ITU. We, as is our normal protocol, kept him sedated and ventilated for 24 hours and cooled him, or at least temperature controlled him, to 36 degrees with a femoral vein cooling device for 24 hours, and then we tried to wake him up. We had 2 goes at discontinuing the sedation. He went a bit wild at both occasions and wouldn't really breathe for himself and behave in any rational way. But on the 3rd attempt, on the 3rd day, they were able to get the NG tube, and he was good enough to be put on the ward at day 5. So since then, from a cardiovascular point of view, as a cardiologist, he's been well behaved. He's been in controlled atrial fibrillation. And of course, we have an issue now about what to do with his antiplatelet therapy. At this minute, he remains on aspirin. I've switched him from ticagrelor to clopidogrel and apixaban. I'm planning to give him just 28 days of aspirin and then discontinue that. And then I'd be interested to hear what other people think. But my plan would be to discharge him home, if we can get him home, on a combination of clopidogrel and apixaban. Neurologically, things remain a bit uncertain. He is making some purposeful movements. He will turn his head to voice, but he's disorientated. He's delirious. He's not really with it. It's going to be a long neuro rehab course, I think. So the discussion points, even patients in whom there is no reason to suspect COVID may well have COVID. As I say, maybe that was the cause of his myocardial infarction indirectly. His neurological status, is uncertain. We don't know what's going to happen to him now. There's always the debate with these sort of patients about which ward should he be on. Should he be on the COVID ward having his rehab? Should he be on the cardiology ward? should he be on a neurology rehab ward? Well, that would be nice, but we don't have one. In fact, what's happened to him is that he was kindly seen by one of our elderly care specialists, despite his age, who opted to put him onto the COVID ward, so he's gone there to be rehabbed with the other COVID patients. Of course, neuro rehab is difficult. Anybody who treats him, including the physiotherapists and the nurses, have to wear full PPE, and it will undoubtedly impair the sort of quality of the neuro rehab that he will get. There are issues about his anticoagulation and antiplatelet therapy. Perhaps one of the things that's becoming evident is that these patients with COVID disease are intensely prothrombotic, and perhaps the anticoagulant in this case, which he needs for his atrial fibrillation anyway, is not a bad thing. What do people think about needing more revascularization? I think it will depend very much on his neurological recovery, but we could certainly consider fixing that diagonal LAD bifurcation lesion if we had to. I think he probably I guess what I would plan to do is pressure wire both the diagonal and the LAD and then act appropriately. But if they're negative, we might leave it. If both positive, then you probably would need perhaps a DK crush procedure to that LAD diagonal. And then the final thing is we need to think about and consider carefully what we're going to do with him in the medium term. If he can go to some sort of care facility, there's been a huge story in the UK about hospitals discharging patients with COVID disease to nursing homes. And then, of course, it introduces the disease into the nursing home, lots of vulnerable patients and lots of mortality. And if the NHS did anything majorly wrong in this scenario, one of the things we did do is we discharged a lot of patients who we knew had or probably had COVID disease back to nursing homes. We've had a bit of a disaster in our nursing homes with lots of nursing homes having high mortality rates in their elderly vulnerable populations. So lots to discuss there. I will stop sharing this stage. So that's my case. I think there are quite a number of discussion points. We could either pick them up now or later as the moderator wishes. Thank you.
Thank you very much, Professor. Very kind of you. I think we had an excellent talk by both of you, which has set the stage for any questions that are going to arise from the participants. I think now we'll have two distinguished panelists. So we'd like to invite our first panelist, Dr. Sinthia Laura from Philippines, to share her experience about COVID-19 and ischemic heart disease management. Welcome.
Thank you very much. Thank you. Thank you. First of all, I'd like to say that I'm very honored to be part of this distinguished panel from Birmingham, from Pakistan. Thank you very much for inviting me. Actually, if you look at the statistics in the Philippines, I think it is not as robust as what you have discussed earlier. The Philippines ranks 38 among the 216 that are registered with COVID cases. In fact, we only have 20,000 patients that are recorded and a 0.05% mortality rate. Now, if you compare the statistics in terms of demographics, majority of our patients are between 29 to 40 years of age. Mostly are males. If you look at comorbidities, I think I would agree with Professor Amara that hypertension and diabetes mellitus are two of the most common comorbidities associated with more complicated course of COVID-19. Now, in the institution that I work with, we have seen patients developing acute coronary syndrome, but unfortunately, during this period of pandemic, all of the units of the hospital were closed, primarily because majority or a great number of healthcare workers, particularly nurses and doctors, were quarantined because initially we had a case which was not actually picked up as a suspect for COVID, and there's a lot of physicians and nurses, residents and fellows who got quarantined and eventually become infected with COVID-19. So that's the main reason why during this period of the early part of March and April, we have to close down our cath lab So for the time being, all of the patients presenting with acute coronary syndrome, majority of them had STEMI, ST elevation, myocardial infarction, were treated with fibrinolysis. And they stayed for around 1 week, 2 weeks. Basically, we were quite successful, despite the fact that we were not be able to give the primary treatment of primary PCI in this group of population. But I think with that limitation that we have in the hospital, I think we would settle for that rather than not doing anything at all. I think one of the reasons why most of our patients with coronary artery disease would not actually go to the hospital during that time is because of the fear of being infected in the hospital. And I think this is one reality that we are still, facing in the hospital in the Philippines. No? If you look at the statistics of majority of the big hospitals in the National Capital Region, most of them are really on the 30-40% operational function. The hospital, as I've said, currently we are on a 30% operation. We are opening this week our cath lab and only accepting elective cases. So no emergency cases yet are being managed. Directive of using thrombolysis are still in place. But hopefully in the next 2-3 weeks, we'll be opening up the emergency PCI for our patients with acute coronary syndrome. The doning and the doping mechanics somehow also serves as a limitation, because it is during the latter part of March that we were able to really master the full protection that our healthcare workers would be needing. And of course, you cannot remove the fact that most of these nurses and doctors are really afraid of being infected, because during this period, majority of the people are COVID suspect. Anybody who presents with cough, with sore throat, they are being labeled as suspects. So basically, all of them are quite scared of reporting to the hospital. So if they have complaints of chest pain, dyspnea, which might be, pinpointing to a coronary artery disease, they would really postpone their visit to the hospital. So hopefully in the next week or so, in the hospital that I work with, we'll be opening up again a lot of units that will serve, of course, patients with coronary artery disease. If you look at the clinics of doctors there, again, we are on our 30% presence of doctors, particularly because of that fear or the stigma of COVID that is still in place in the community. So hopefully in the next months, we will be, the new normal as it should be.
Dr. Ishaq, we are not hearing you.
Can you hear me now?
Yes, that's better.
Okay. Thanks to Professor Sinthia De Laura for her presentation. I think it's very important that we have data from various countries so that we can come up with a consensus how best to manage the patients in our own scenario. Now we have another very senior panelist, Professor Saulat Siddique, Professor of Cardiology at Lahore, and also our current president of Hypertension League. I would request him to kindly give his comments or his experience, his suggestions, or whatever he has to say about ischemic heart disease management in the COVID-19 era, just to add on to Pakistani experience and flavor. Professor Saulat Siddique.
Thank you, Dr. Ishaq. Well, anyhow, first I'd like to point out that I'm not working in the clinical hospital at the moment, so my experience with COVID is limited just to the outpatient, and that is very limited. So I leave it to those who are working in the clinical setting, in the acute setting. Couple of questions or clarifications from Dr. Sohail. Excellent presentation and excellent work done over this period. I heard a previous lecture from a doctor in New York, actually intensive, was doing interventional cardiology. And he did tell us about a number of cases which presented the typical features on the ECG of an acute ST elevation MI, but no coronary lesions, more than one patient. So that is something interesting, which apparently Birmingham didn't find. So that's one thing. The other was the data from the Italian MI data, and mentioned that 2.5 times increase in MIs. Were these in COVID positive patients? That's the first thing, because as you had earlier pointed out, there is an imbalance in supply and demand. So was it an MI caused by the demand and imbalance caused by the COVID infection? And the third clarification is screening for asymptomatic staff. Do you do PCR or antibody, and how do you interpret it? Because that is the problem with especially antibody testing. How are you going to interpret it in the asymptomatic staff?
Yes, so thank you, Professor. So, yeah, so it's interesting. Different hospitals have had different experiences, and what's interesting is actually a lot of what we're seeing around the world seems to be similar to the experiences that we've had as well. So I was just listening to Dr. Delara and some of her experiences in the Philippines, and we've seen those also in terms of dropping in numbers, concerns about patients wanting to come into hospital as well. So going back to the data from New York, there was an article which was published in the New England, and I think there were not too many cases that they reported. I think there was something like 16 or 17 cases reported from 6 centers in New York, and 1/3 of those showed ST elevation, but unobstructed coronary vessels. I have to say that hasn't been our experience at all. And I think what we're seeing is slightly different experiences, and it may be to do with the patient demographics. It may be that our numbers have dropped off so much that actually patients are not presenting to us anymore. So we haven't seen during this time evidence of Takotsubo, for example. But, you know, as was mentioned, we had a very sort of sharp burst of cases in April, and then a quick fall off. So it might be related to that. I don't know. I think what's evident is that we're still sort of in the early phases of this, and we're still very much learning about what the disease can do. As far as the Italian data is concerned, I think all those patients were a mixture of patients with NSTEMI and STEMI, and also a mix of patients who were COVID positive and COVID negative. So they were just sharing their experiences of all patients who had presented. I think there were only 44 cases in that series, but clearly they showed an upsurge in the number of cases. Now, the European Society of Cardiology have been busy, so they've been polling centers around the world. And actually, not all centers have seen a decrease in numbers. I think there were only around 80% of centers that actually saw a decrease or substantial decrease in their numbers. 20% actually saw an upsurge in their numbers, and it's not entirely clear as to why that is. And I think we will probably learn more as the pandemic progresses. What we've seen in the UK, and only yesterday I saw an advert in the newspaper reminding patients that hospitals are still open for business. So in the Guardian yesterday, there was a supplement talking about you know, if you have chest pain, if you have atrial fibrillation, if you're feeling unwell, you should still be presenting yourself to hospital. I think there is this big concern of patients that they are going to catch the virus in hospital. This is not a unreasonable concern, because, you know, the latest data that we have suggests that 20% of hospital staff have the virus or have had the virus. So, you know, that is a genuine concern from patients. And I think one of our roles is to try and protect the patients. And this is what we're doing. So we're an acute hospital. So we've got sort of hot zones and cold zones, and we have to get that information out that patients will be safe if they come to hospital. We as staff will be wearing full PPE when we're looking after these patients. And I think it's about timely treatment as well. So we have to think about changing some of our pathways. We have to treat these patients more quickly, minimize the number of staff that they are in contact with so that their risks are minimized. As far as screening is concerned, I mean, the concern is always the asymptomatic individuals. We saw some cases from Singapore, from South Korea, where one person was potentially responsible for spreading the virus to many thousands. How do we tackle that? Well, the only real way to tackle that is either through testing. You have to have mass testing available, or you have to have a policy of social isolation and social distancing. These are the only two ways to get about and around that situation. Now, testing obviously has been a bit of a concern, but certainly in the UK, we've seen an uptick in the number of tests that are being performed now. And as I said, our hospital has taken the policy that actually they will do testing for all staff, the swab test if there is concern about COVID, or the antibody test, which is a blood test for individuals if they think they may have had the virus. What we don't know at this stage is whether having the antibody will give you long-term protection. We think it will give you some short-term protection. It's not clear whether you will have any long-term protection. I think what everybody is waiting on is actually the vaccine coming along, aren't they? Because there's very little in terms of drug therapies that are turning out to be positive. We have several studies ongoing at our institution. So,
thank you, Sohail. Thank you, Saulat. Have you got any questions? If not,
Yes.
that I have got a couple of questions.
Just follow up on that. Would you prefer the swab, the PCR, or the antibody for screening purposes?
Well, for screening, I think you have to do the swab test. That is probably what's recommended by WHO.
And then no discussion on COVID is going to end without chloroquine and hydroxychloroquine. So just yesterday, I was reading that recovery trial in UK has been, the regulators have opened it up prematurely. Yes. And it didn't show any benefits. So what's the final? Is that the final word?
So actually, let me just, I've got a couple of slides on treatment. So let me see if I can share that with you. Can you see that?
Yes.
Yes. Okay. So just very quickly, there are treatments that are being considered. So at our hospital, we're taking part in the recovery trial. This is essentially a 4-arm trial. You've got the drug lopinavir, ritonavir, hydroxychloroquine, azathioprine, and then a combination of hydroxychloroquine and azathioprine. Now, as you're quite rightly said, Professor Siddique, as of yesterday, the hydroxychloroquine arm has been terminated. So the Oxford group that were running this trial have looked at some of the data through the Data Safety Monitoring Committee and have decided that actually it's not that hydroxychloroquine is bad for you, but actually there isn't any difference in mortality in those who were given either standard of care therapy or indeed hydroxychloroquine therapy. So as a result, that arm has been closed. Some of you may have seen the trial that was published in the Lancet. I don't think we should talk too much about that. That trial has been redacted. That seemed to suggest higher mortality in the hydroxychloroquine arm. Yeah. There are other studies which are ongoing, including convalescent plasma steroids, and then of course we've also seen some of these immune modulation drugs as well, sort of interleukin receptor. Now, what we know from the virus perspective is it probably comes in 3 phases. So there's this sort of constitutional symptoms that the majority of people will get. There's the pneumonia phase, and then fortunately, very few people will get the inflammatory cytokine response. And it might be that different drugs are beneficial at different stages of treatment. Certainly, you wouldn't want to give steroids during the pneumonia phase, and maybe the interleukin receptors are not going to do very much for individuals if they're not going to end up requiring or ending up with a cytokine storm. Other trials that are ongoing, well, we've heard a lot about remdesivir. This is a nucleoside analog. There was some data which showed no difference when it was given for 5 or 10 days. There are other studies which have shown shorter time to recovery, and this has now been made available in the UK after the European Medical Agency approved it for compassionate use. It's also available, I think, in Japan and also India and United States. But the problem is actually availability of the drug. So, although it's available to us, it is being given only on compassionate use basis, and with the say-so of pharmacy and respiratory consultant as well. So at the moment, the trials, we're hoping that the recovery trial will show some benefits. They have recruited over 11,000 patients, but there are numerous agents that are being investigated, but none so far as I'm aware, have shown any benefit whatsoever. And certainly what we shouldn't be doing is following the advice of certain presidents around the world.
Thank you, Dr.
Hi, let me share my experience with treatment for complicated type of COVID-19, because during the early part of this pandemic, we really saw a lot of complicated cases for young patients. And in fact, we have some healthcare workers who got infected. And during this period of cytokine storm, we have given all the treatment that Professor Amara has mentioned. That patient was given steroids, patient was given azithromycin, he was also given a convalescent. The patient was recovering. We really are wondering what really made her well. Is it the antiviral? Is it the antibiotic? Is it the steroids? Or is it convalescent plasma? But what's important is she got well. Well, apparently during the later part of the month, we have seen very mild cases of COVID-19. In fact, around 0.10 to 15% of these cases were not even given treatment at all. So, we are quite a little bit, monitoring closely these patients. So they are sent home with mild on isolated quarantine. But for patients who have pneumonia, of course, they become admitted. But as I've said, the cases seems to be very mild at this time. So I'm not sure whether you see the same occurrences in your institution or in your country.
So I can certainly give you some of our experiences. So, we changed our rotas and moved to a 4-on, 4-off. And when we did this, we became frontline medics in the fight with COVID. And I have to say, I happened to be on call during the 4 nights, which were probably the busiest nights in our hospital. I saw, apart from 1 or 2 patients, everybody who was coming through our front door at that time was coming in with pneumonia. And they were all COVID patients. And that x-ray that I showed in my talk, that was the x-ray of a patient I actually decided to send home, believe it or not. I've never sent anybody home with bilateral pneumonia before, but that was the first time I had to do that because we were going to get swamped otherwise. So we had to make these decisions about patients, and I'm hoping that these patients that I sent home did well. But if their saturations were fine, they had good support at home, they lived relatively close to the hospital, the decision was actually that they should be sent home rather than admitted at that stage. I think what's interesting is the different demographics and the different populations that we have. So I think one of the reasons why we have been struck particularly hard is the elderly population that we have in the UK. So if you look at the average age of the UK population, it's something like the mid-40s. I think Italy have an average age even higher than that. Whereas if you look at Asia and African countries, the populations are a lot younger, aren't they? So certainly in Africa, the average age is in the 19s or 20s, and maybe in Asia, sort of mid 20s. And we know that age is a big risk factor in terms of the virus. So you're more likely to die if you're elderly.
Sohail,
Thank you.
Can I ask you a question?
Yes, please.
So, what's your take on the ethnic issue? I mean, it's been slightly seized upon in the UK by some politicians who are claiming that we are underserving the black and ethnic minority population and should be protecting them more.
Yes.
My take on it's been that it's largely biology rather than sociology, but what's your view?
No, I think you're absolutely right. So I don't know if colleagues are aware in Philippines and also in Pakistan, but we saw a big uptick in the number of individuals who passed away with the virus who were black and ethnic minority. And unfortunately, many of our nursing staff as well who are from the Philippines. Now, what's become evident is that there is probably an increased risk if you're ethnic minority, but it's difficult to tease out whether that's because they live in households with in bigger families, or whether it's to do with deprivation, or whether it's the fact that they're more likely to be frontline workers. So a lot of the staff, for example, on buses, on public transport, particularly in London, are black and Asian. A lot of the cab drivers as well, and a lot of healthcare staff within the UK, particularly frontline workers, are from ethnic minorities. So I don't think it's to do with genetics. I think if it was to do with genetics, we would see higher numbers of individuals, unfortunately, passing away in our Asian countries, which we're not seeing at all. So I think it's more to do with the fact that these individuals have more risk factors. We know that particularly the Asian population within the UK are more likely to be on treatment for hypertension, more likely to be diabetics as well. So it's probably a multitude of factors and probably unlikely to be related to genetics, in my opinion.
Yeah, I mean, there's no doubt.
Thank you very much. I think in interest of time, because we have got allocated time up to 4 o'clock, we have to stop before 4. We have a number of questions that people keep asking us, you see, and I would like to take this opportunity to benefit from all the 3-4 speakers and panelists that we have. One is a question about the use of ACE inhibitors or ARBs, because of a lot of confusion going on in the media and also in the literature about whether it's beneficial or it's harmful to continue taking ACE inhibitors, ARBs. I know that there is a policy statement by European Society that there is no harm, you can continue taking it, but people keep on asking. So may I ask Professor John Tonin to address this question? And another question for Professor Sohail, what's your recovery percentage? What sort of people recover after admitting, you see, in the Queen Elizabeth Hospital? And how do you compare the in-hospital mortality with the community-based mortality that we have? And whether the age has got any major bearing, because we are seeing a lot of young patients here succumbing to death with coronavirus, very healthy people. Initially, we thought because of the old age and immune suppression and whatnot, but we have seen some very young, robust people dying. So these are a couple of questions, and the role of steroids, because we think that's a myocarditis. There's a postulation there's a myocarditis. And one another query that is very often asked, and it's a little puzzle for us. People presenting with classical ST elevation changes on ECG, having no obstructive coronary disease, short of taking them to the cath lab, how can we pick up from any clinical marker and save them from taking to the cath lab that these patients are suffering from COVID and they're not coronary disease patients as such? So these are a couple of queries that I would like you to share among yourself and shed some light on these. Thank you.
Yeah, in terms of the ACE inhibitor ARB debate. I mean, this has been a big issue, and I was swamped with questions from patients and GPs about this one. You know, you have to remember that a third of our population are hypertensive, and probably another third are undiagnosed hypertensives. But if a third of our population are hypertensive, that means that the majority of those will be on ARBs and ACE inhibitors. So it's a hugely common problem. I mean, my view is that these drugs have known prognostic benefits, and although there are some concerns on biological grounds about whether they may be deleterious in COVID infection, we have no evidence to that effect. So I've strongly backed up the ESC guidance, and I've advised my patients that they really should not discontinue these medications. They should absolutely stay on them. There is even some work that's been set up. I'm not sure how far it got, but that actually, you know, if you follow the biology right through, that maybe even these agents are beneficial. But certainly in the absence of any proof of deleterious effects, I have been suggesting that my patients continue these medications without interruption. And in terms of the ST elevation myocardial infarction question, I think that's fascinating. And in fact, we had a little poll the other day among all the interventionists at the QE to see how many of us had seen ST elevation myocardial infarcts with normal coronary arteries in COVID patients. And I don't think between us we could find one. And I think ultimately, you know, there probably isn't a diagnostic test, because even if you do an echo in cases of COVID myocarditis, you're likely to see a regional wall motion abnormality, you're likely to see a troponin rise, and you will have the ECG change. So ultimately, you probably will, if you really want to be certain, you may need to do that angiogram, I'm afraid. So I'd be interested in Sohail's view.
Thank you, John. I think we have a lot of other questions, but in the interest of time, we'll have to be short. There's one little query that how useful the echocardiogram is in the initial assessment of patients presenting to us with suspected COVID-19 and having any cardiac involvement. And secondly, we had a presentation some time ago from New York, and the gentleman was telling us that most of these patients have got clot formation in their arteries. So it's a widespread thrombotic disease. You see, you get thrombus everywhere. So is there any point giving them a prophylactic anticoagulation or sort of antiplatelets in that dosage? I mean, there's a lot of confusion in this area. Sohail, would you like to make any comment on that?
Yeah, so very quickly, yeah. So as far as the steroids question go, I think we're going to have to wait till the trials come out and tell us what we should be doing. You know, initially there was concern, and lots of patients stopped their ACE inhibitors, and subsequently we found out that actually they should probably have carried on with their ACE inhibitors and ARBs. So we really have to wait for trial evidence and randomized controlled trial evidence before we start deciding on what treatments we should be giving and should not be giving to individuals. The REMAP CAP trial is going to look at low molecular weight heparin, prolonged low molecular weight heparin in patients who are admitted with COVID up to 14 days. So that will give us some evidence as to whether or not it is beneficial. My personal view is that these patients, when they're admitted, should probably be given low molecular weight heparin at low dose, so not therapeutic for ACS or PE, but just low dose low molecular weight heparin, whichever low molecular weight heparin that you use. I think what we're seeing in terms of high thrombotic load, part of that might be explained by late presentation. So, you know, we know that if you present late, you're more likely to have thrombotic coronary lesions rather than if you present early. So, you know, I don't think there's any one center which has seen huge number of cases. We've all seen cases with high thrombus burden. But we've seen this outwith of the COVID as well. So it's difficult to know whether that's all related to the COVID virus itself. Although, as I suggested in one of my slides, there are putative reasons as to why it might cause a vasculitis as well. I don't know what Dr. Dr. Lara thinks and what her experiences have been about this.
Well, basically what I said earlier, we really been using steroids, especially for very complicated COVID cases, despite the fact we don't have any randomized controlled study that would really back it up. If you are confronted with a dying patient, you really have to give everything that is on hand. So currently, so we don't give so much steroids. Basically just for severe pneumonia, especially if you detect there is really severe cytokine storm. And if you look at recovery rate, I think the Philippines has a good recovery rate now. As I've said earlier, we see a lot of mild asymptomatic cases. So basically the storm, the cytokine storm that we have been experiencing was hopefully ended, and hopefully we'll not have a second wave anymore. Now, there was a question of whether the utilization of 2D echocardiogram, whether it's an ACS or is it due to COVID-19. I think it's very difficult really to look at the echo as the only test to differentiate whether this is really an ACS or myocardial injury brought about by direct toxicity of COVID-19. You need further testing like serial monitoring of your ECG, troponin escalation, and the 2D echo should not just be the only test, but probably it should be complementing all the other tests so that it would somehow give you a better understanding of whether this is due to the direct effect of COVID-19 or an acute coronary syndrome.
Thank you very much. Just one last question. I think I did ask Sohail about the recovery percentage of people recovering at your hospital. And is the mortality different from the community in the hospital, or is it comparable?
Yeah, so I can't really comment on mortality in the community because I don't have access to any of those figures. But what we have seen is non-COVID related deaths have certainly increased during this time period. And part of that may have been related to what was suggested by Dr. De Lara, that people are concerned and worried about coming to hospital, even for life-threatening conditions. In terms of our hospital statistics, I've been told that we had one of the best survival rates in the world in our intensive care units, something in the order of around 60%. Now, I haven't seen the full figures, but part of that might be selection, the sorts of patients that you're admitting to the unit. What became clear quite early on was that elderly patients were not going to do very well on ventilators, and we gained some of this experience from colleagues in North Italy. So, the chance of going onto a ventilator was actually quite low if you were elderly, because your chance of survival was going to be minuscule. And unfortunately, these are the sorts of things that you have to do during a pandemic. You have to make decisions, warlike decisions almost, during pandemic crisis that we're currently in. I'm interested to hear about your experiences about younger individuals having caught the virus and not done terribly well. Generally, our experience has been is that younger patients do tend to have a stormy course on an intensive care unit. And remember, the average stay of these patients on an ITU is 2-3 weeks. I've seen patients on our intensive care unit, young individuals who've stayed for 4 weeks. So, the concern about not enough ventilators was partly related to the fact that actually patients who were requiring ventilation would require it for a longer period of time as well. So that's been our experience on our intensive care unit. Very similar to Dr. De Lara, I guess what we don't really know is how many asymptomatics there are out there in the community. And of course, for the majority of patients, the majority will actually have very mild constitutional symptoms. They will never come to us. We will only really see the severe end of the spectrum. So, we have a skewed population. We're seeing the patients with bilateral pneumonias and those very few, fortunately, who will require ventilation because of the intense cytokine storm that they will encounter.
Thank you very much. I have plenty of other questions on behalf of participants, but I think in the interest of time,
sorry,
our time is up. Okay,
hello?
I think we have one
Is it okay?
participant from NS. Yes, you can talk, please.
Oh, sorry. So we, I mean, there's just a few quick questions that I've got is, first of all, I mean, thank you so much for the talk, and it was very nice. Dr. Sohail and everybody else, all the participants and everybody, all the lecturers. So, I mean, I work in a it's a tertiary hospital. It's a massive heart hospital where I am. It's NICVD. So I have a few questions regarding the recurrence of COVID. How many patients do you have who've already been diagnosed previously and have had immunity, but they've come back? And if they come back, has it been worse symptoms as compared to the first time? Have you had any of those cases? And also, how long would it take for it to show up on an X-ray? Because we've got people that we've got a lot of patients that they are coming in, and we're too scared to treat them straight away. So we want to get the X-ray done first, and we've been told that the X-ray would show some sort of bilateral infiltrations, which would want you to treat them differently. Because one of the talk also said that we have the same sort of mimicking an MI, but normal coronaries. So we've also seen patients with that, which have got STMI, and when they get taken to the cath, they realize it's normal coronaries as well. So how long would the X-ray would take, in your, I mean, a rough idea, for them to show the bilateral infiltrates, and how many cases have you seen, if any, recurrence of any cases? Thank you.
In terms of recurrence, I can't really comment. I have not seen any recurrent cases or been told about them, but I'm sure it's happening. I'm afraid I just can't give you any information. In terms of the chest X-ray, it is well reported that the chest X-ray is less sensitive than a CT scan. So if you've got the facilities, my strong advice would be to get the CT scan done as soon as possible. You can see quite nasty ground glass infiltrates on a patient who has a pretty normal looking chest X-ray. So the first test to do if you're suspecting COVID pneumonia is to get the swab done, obviously, but the second thing is just to get them through the CT scan, and you should get a result within 10 minutes. It's a very sensitive, rapid test for COVID pneumonia.
Thank you very much. If there's no other question.
Right. Thank you so much, Dr. John. Just one more feedback. It's not a question. We also have the same sort of hot and cold area in our ER, where we've divided between hot and cold. So patients are very scared of coming in, because they're really scared of even coming in with an MI. They would be worried if they were going to be putting them in COVID. So we're facing the same thing. So it's good to see that across the world, like, I mean, the hospitals have got similar protocol. And just one thing that we would want to do is make sure that even asymptomatic staff should get tested. As you just said, in the UK, you've got that coming up. We don't have that as yet. So, but yeah, thank you so much for this talk. It was very interesting and very good to come across this talk. So thank you.
Well, thank you very much. I think we can go on for another hour or so. A lot of things to learn. But I think in the interest of time, I would like to thank all the distinguished speakers, in particular Dr. Sohail, Dr. Professor John Tonind, Madam Laura, Professor Saulat Siddique, and the participants, and of course, Getz Pharmaceutical, Mr. Qadir Khan and Mr. Zain, for their collaboration and support. I think it has been a very interesting session. We have learned a lot. It's a new disease. We have to learn a lot more about how best to manage it. I think as time passes, we are getting more and more insight into the problem. And I think this kind of exchanges are extremely important, because different countries have got different kind of systems of healthcare, and they're seeing different type of people. You see different age groups, ethnicities, social economic backgrounds. And I think it's very important that we exchange among ourselves and find out what is the best course of treatment and management for these patients. We are seeing a lot of patients here who are sort of hesitant to go to the hospitals because they think that once they go to the hospital, their chance of survival will be very low. And there's a lot of fear more than the disease. The fear has really overtaken the disease itself, you see, and people are under tremendous stress because they don't know when they will get it, who has got it. They are very reluctant to go out of the hospital, their houses. We had a lockdown which probably did little good for us, but at the same time, it was difficult for us to continue the lockdown in terms of socioeconomic implications. So now we are in a sort of smart lockdown. We're trying to stay at home. We are trying to minimize our exposure and crowds, but I think it's very difficult to tell the people and educate them. So I think with this, the hydrochloroquine doctrine is coming up very fast. At least in India, there's a policy statement by the government of India to use hydroxychloroquine for the healthcare workers. A lot of other things are coming up, antiviral. Let's hope that we have a vaccine as soon as possible and we can get over this, because the life has changed, the whole world has changed and become very boring, and we can't travel, we can't meet our friends, we can't meet our families. So let's hope that all this goes back to those nice good days that we used to interact and sit down together and gossip and meet people and embrace them, you see, very fast. So I think, thank you very much, all of you, for being with us this afternoon. We hope to have these again. And I am very grateful to Getz Pharmaceutical for helping us. And I'm grateful to all the speakers and the panelists and the participants. I got a lot of questions on my table from the participants, but I think in the interest of time, we had to close it down. Thank you very much and have a nice day. Have a nice Sunday tomorrow. I hope Birmingham weather gets better and you enjoy the sun tomorrow. Thank you very much for being with us. Thank you.